So we'll go to the case. So this is the history. She's a 27-year-old female, an engineer by profession, limp with the left hip since childhood, increased pain for the past 6 months, and about with a 10-degree adduction deformity, 2 centimeter of true shortening, and the spine examination is normal. Yeah.
Okay, so what's going on here? Anyone want to tell us? Yes, Dr. Bandit. What?
It looks more like I mean, the first impression to call it as a dysplastic hip.
Yes.
It looks more like a slipped epiphysis which has not been corrected completely. There is a physical difference between two of them. The dysplastic hip has an excessive anteversion, while these one have excessive retroversion because the head has slipped inferiorly and posteriorly.
Right.
So we have to go into.
So you're looking at the lesser trochanter to make that judgment?
Yeah. No. We have to take a CT scan to see exactly what's the position of acetabulum.
Yeah.
We need to take a transverse section to see exactly how the version of the acetabulum on the left side is compared to the normal one.
Okay.
That way we can actually get the idea about how the cup should be placed. And in this particular patient, we like to set the cup medialized to the bottom of the acetabulum. And I wouldn't mind taking maybe up to say 5 millimeter proximal position to get a better bone fit.
So you don't mind if you proximalize your hip center by 5 millimeters?
5 millimeters, it should be allowed to get a better bone, and you can get a primary fit without requiring any extra bone graft or augment.
Yeah.
But that decision is done after taking the CT scan planning. And for the femur, if there is no significant retroversion of the femur, you can use a standard cup, or you may have to keep something like a SROM implant available because you can then change the rotation.
So if you need to correct the version of the femur, you may need an implant that allows you to do the ESROM or some other component.
One very important thing in this, the neck cut level. Sometimes the neck cut has to be almost through the head.
Yeah, sure.
So the moment if you do overcut the neck, then it's a problem.
So what is
Yep. Sorry, one more thing is, this is developmental. It is probably from the young days of a child. So what happens is there is a discrepancy of a limb length. You want to get it right. The sciatic nerve has not grown to that level.
Yeah.
The difference between the shortening when it is developing from the young days and something which has happened later, like an excision hip done in adulthood.
Yeah.
So here if you try to elongate, there is a higher risk of getting sciatic nerve palsy, and you should have a low threshold to use the subtrochanteric osteotomy if you feel that a sciatic nerve is getting at a stretch, if you try to get the limb length equalization.
Okay, David, you look like you want to say something.
No, so I just have 2 questions that I think we're going to, one has to do with leg length and how much everybody would actually lengthen this leg, because I would not lengthen this leg back to equal to the other side. I'd do less than that.
Yeah.
And the second is this x-ray, there's also pelvic rotation. We talk a lot about sacral slope and pelvic tilt, but we don't talk a lot about pelvic rotation and what that does to your version. So just how you address that.
Yes.
Yeah, they're good questions. So would everyone would go for some length, I take it. Would anybody lengthen it by 2 centimeters? Would you lengthen it by 1 centimeter? 1.5, Amar?
Well, yeah, I think the point to be made is she's been short her whole life, and so therefore you don't have to equalize her.
Yeah.
Number 2, I think Harish said if you put her cup in a modified high hip center, you'll gain some height there, because you're automatically going to lengthen her neck by replacing her hip.
Right.
Right. So you have to offset that increase in your neck length from the reconstruction of the femoral side by moving your hip up. Otherwise, you will lengthen it, it'll be too tight, and you can get into a problem.
Do you think you need a subtrochanteric osteotomy in this case?
I don't think you need to do it. I think if you do the things that I just mentioned, you'll have a short neck, but raise a cup, and then it'll be fine.
The one more point is here, the inlet-like appearance of a pelvis is more because of flexion deformity probably she has in her hip.
So she's got an
and spine may be normal.
Tilt.
The moment you correct it, it's going to be gone.
Right. So she's got an anterior pelvic tilt, a hyperlordosis, because she's got a flexion contracture in her hip. When you fix the hip, the pelvis will roll back. That'll increase your inclination and increase your anteversion. So you need to be aware of that.
And one has to be careful about the exposure also, because sometimes the exposure in these cases, if they are the sequelae of any infection in the childhood, becomes very difficult.
Okay, so she may have scars or infection in the past. What about the positioning? Is that going to be, or the approach? So I take it you'd all do your routine. Would you do an anterior approach for this? If you,
I will do a standard posterior approach.
Yeah.
I will medialize the cup. I think there is a lot of medial osteophyte. We can medialize it. We can get adequate coverage for the cup. Wouldn't go for chasing for a higher hip center. The only thing I would suggest, I probably will get it out to full length, but we may not be able to restore the offset as compared to the opposite side. And I will keep short neck stems available here because a standard offset might be a little bit too tight for this patient.
yeah.
So I
Okay,
think,
so you got some more imaging for
yeah,
us?
very
or-
good point. So next, the imaging, as one of our panelists had said, CT scans. So always when you have to calculate the version, this is an example. In the same patient for the right side, it's done with your calculation of the distal femoral condyles, and this is how when the subtraction is done. So it's
the
about
anteversion's
0.5 in the right side, and in the left side, this is the one. So it's about 35 degrees in the left side.
So she's anteverted?
Yeah,
Not,
the
we
femoral.
thought, we were thinking she might be retroverted, but she's
Yeah.
actually got excessive anteversion. 18 degrees, was it, on the right?
On the right, it's less than 1 degree. On the left, it's 35 degrees.
So go back to your other image. Right, so,
Yeah.
so that's but then the previous image.
Yeah.
So isn't that the right knee
Yeah.
internally rotated? So if you measure the anteversion from the posterior condylar axis, don't you have anteversion of 18 plus 0.5?
Yeah, no, and then you subtraction due to the rotated femoral condyle. So this is done by the radiologist.
I see. So that's after the, I don't know.
Yeah.
Oh, I see. They've rotated that image at
Yeah.
the top, have they? Okay, so it's 0. Okay.
So this is what we are looking at now.
So there is excessive anteversion.
Yes.
So would the panel use a standard stem, or would you want to correct that with a stem that allows you to correct the version? Ezra?
Maybe S-ROM, because even the canal is very narrow
Yep.
in that patient.
So go back to the AP radiograph for us. How narrow is the canal?
Yeah. So this is what.
So you would think, so you don't want to use a cone type stem, you want to use an ESROM because you think the canal's narrow? Yeah?
I'd probably use more of a Wagner cone
Would-
type stem that
yeah.
you can rotate wherever you want. The other thing to look at here is there's not much medial takeoff of that calcar. So
Yeah.
to put any stem in that has a metaphyseal flare is going to be difficult.
Yeah, so you mean with the ESROM, it might be reaming out into the soft tissues?
I don't know about here, but the SROM stem is no longer available.
It's pulled
Is it
out
no longer
of the
available?
market.
They're
so-
not making them anymore, so there's still some that are around, but
Yeah.
they're shortly going to be not available.
That's amazing.
The problem with Wagner cone in India is comes with a very small offset. I don't think they have kept both. Yeah, this will be good. Tailor-made for this one.
And the problem with ESROM in India is that they are still giving us 11, 13 heads. So if I have to revise one of them with another head, I'm sunk. I'll have to take
11,
out the stem.
13, yeah.
All the sizes are not available of the S-ROM.
Yeah, okay, I didn't know they'd stopped making it, wow. We still can get it in Australia, but they've cut down the inventory, but it's still, that's amazing. They're good at withdrawing stuff that works and keeping stuff on the market that doesn't.
Yeah.
Okay, what else have you got for
Yeah.
us?
So just for the templating, right? So that's a discussion which we had with all our panel, whether we bring it down or we accept minimal amount of high hip. And the other one, is what is the choice of stem? So that was also our dilemma, whether we have an S-ROM
Yeah.
or we use a cone Wagner. So this is what we did, and
Okay.
so a bantam size 44 cup cone Wagner. Now the wire was actually done prophylactically, just because you get small splinters when you do the final tapping. So prophylactically wiring and a 135 degree Wagner stem, cone Wagner. So cone Wagner comes in two sizes actually. It's 125 and 135.
Okay.
And
So,
And you see, you have done the medialization of the cup, and that has gained some amount of offset.
yes.
yeah, so it's more offset than pre-op because
Yeah.
you've reduced the
So any
anteversion.
comments from the
That's
panel?
exactly where the cup needs to be.
Right?
That's exactly where the cup needs to be. If you put the cup in the anatomic position, you would not be able to do this hip.
Yeah, okay, good, well done.
So I also just think that putting that prophylactic cable or wire on is a very smart idea. These cases are hard enough. The last thing you want to be dealing with is an
Yeah,
intraoperative
fraction.
crack. So if you're at all worried about it, it's easy to put it on. It's something you should do.
What do you do if you see a crack intraoperatively, David?
Take the stem out, put a cable on, put the stem back in.
Yeah.
Okay,
Yeah, a little bit more taps, it just gets it, yeah. So, 6 months down the line, Limlin's are clinically fine, about 5 mm shortening, she's back to normal. So just to conclude the key learning points, I think the preoperative planning with the imaging And we should not hesitate in getting more imaging, even if it's a CT scan. Modular stems, Cone Wagner, SROM, especially for these dysplastic hips, and also minimal amount of high hip center. I think that's got a very good role for you to get the offset also.
Okay, fantastic.
Thank you.
We're out of time, but that's great. Thank you very much.